Welcome to Clot Chronicles. My name is John Fanikos. I'm a pharmacist, and I also serve as the Director of Strategic Initiatives at the North American Thrombosis Forum. Today, we're going to review a recently published article, Optimizing Antithrombotic Therapy in Patients with Coexisting Cardiovascular and Gastrointestinal Disease. I think it's an important article because it was written by a number of experts in the field of anticoagulation. And they provide a number of recommendations, I think, that can be helpful to providers that are dealing with these patients on a day-to-day basis. So I've got a brief outline. Let's start by looking at the effects of gastrointestinal disease on pharmacodynamics. So the authors put together this illustration. To the left, you'll see the armamentarium of antiplatelet and anticoagulant drugs we have available. In the center, you'll see a depiction of the gastrointestinal tract, including the stomach, the small intestine, and the large intestine. And I think what you'll appreciate is the different drugs are absorbed in different locations along that gastrointestinal tract. The aspirin, warfarin, rivaroxaban, and dabigatran typically absorbed in the stomach, whereas apixaban, edoxaban, and our antiplatelet agents are typically absorbed along the small intestine. In the top right of the screen, you should recognize that some patients suffer from short bowel syndrome, where stretches of the gastrointestinal tract are not functioning properly. There's a number of patients with immune conditions like celiac disease, where items like gluten can affect the absorption of nutrients and medications. And finally, the presence of disease, like malignancy. If you look to the bottom, the solution for many of these issues is to perform surgery that will alter how the gastrointestinal tract, and specifically the stomach and small intestine, will function. And then after surgery, we often add medications that will alter the acid-base balance and affect the absorption, again, of nutrients and medications. And then finally, the absorption of nutrients and medications is done automatically. And so there are medications that can affect the motility, the passage, the length of time, either shortening the length of time or lengthening the length of time that medications pass across the gastrointestinal system that may affect the ultimate absorption of the medications and their effectiveness. This is the central illustration from the article that depicts the different anticoagulant and antiplatelet medications and the different areas where there's potential complication. The authors have depicted green, yellow, red, and blue as a signal for either green being no problems, yellow being an area of uncertainty, red being an area of potential problems, and then finally the blue designation, which typically suggests that we should do additional monitoring. And I'll draw your eyes to the first box on the upper left-hand side of the screen in the setting of bariatric surgery. You'll see that the different characteristics of the drugs become important in the setting of gastrointestinal disease. In this example, warfarin and apixaban appear to be safe and effective when given in the setting of bariatric surgery. But if we drop down to resections of the small intestine, we'll see that drugs that like apixaban and rivaroxaban may be a problem, and drugs like edoxaban and warfarin may be a better choice. So I would suggest to you, take out your cell phone, take a picture of this central illustration, and carry it around with you as a source of information in terms of medication management in gastrointestinal disease. We don't have a risk scoring system to identify patients who may develop gastrointestinal bleeding. And so the authors have come out with a series of recommendations. Here are the recommendations in the setting of antiplatelet therapy in patients that have low to high risk of GI bleeding and low to high risk of thrombosis. And I think what's important is the authors recommend that you typically use this de-escalation strategy, moving from combinations of antiplatelet and anticoagulant therapy to monotherapy, moving to a shortened duration of therapy, and then finally moving to a lower potency of therapy. And so this is the strategy that they're typically recommending in the setting of antiplatelet therapy. In the setting of GI bleeding risk with anticoagulant therapy, they have come to the conclusion that apixaban is probably your best option. as an anticoagulant. And again, the de-escalation of combination therapy to monotherapy. And then finally, if you're in the setting of anticoagulant use, dose adjusting downward if there is a high risk of gastrointestinal bleeding. They have recommendations to protect the GI tract from any type of GI bleeding occurring. They have taken the recommendations from professional societies, and I think the takeaway message here is it's safe and effective to protect the gastrointestinal tract with the use of proton pump inhibitors or H2 antagonists in combination with anticoagulant therapy or antiplatelet therapy as a method of avoiding complications. Now, what do we do in the setting of active GI bleeding? Again, the authors have come up with a series of recommendations in the setting of severity, high or severe gastrointestinal bleeding versus low severity of gastrointestinal bleeding in the face of thrombosis risk. And the recommendations in the setting of antiplatelet therapy in acute bleeding event is to stop or discontinue antiplatelet therapy for at least 5 days. This is an important aspect in terms of restarting at some point in these patients. And then in the setting of a moderate bleeding event, withholding again antiplatelet therapy for 3 days. In the setting of a minimal or low severity GI bleeding risk, the authors are recommending continuing antiplatelet therapy. Similar strategy in the setting of anticoagulant therapy in severity of gastrointestinal bleeding. In a high, severe, or severe bleeding event, the authors are recommending stopping anticoagulant therapy for 1 to 2 weeks, stopping in the setting of moderate GI bleeding for at least 1 week, and then finally, in the setting of high thrombosis risk and a low severity bleeding event, they are recommending continuing anticoagulant therapy. So a number of different strategies are emerging that are recommended by these experts. So I want to finish, and I think there's 4 key points here to cover. One is the pharmacodynamics of the drugs and tailoring the therapy specifically to the disease that's present. For the warfarin, we can obviously closely monitor INR in the setting of gastrectomy or short bowel syndrome. Apixaban has emerged to be the preferred anticoagulant after gastrectomy, whereas in the setting of short bowel syndrome, rivaroxaban or edoxaban may be the preferred agent. In the setting of bariatric surgery, there is more and more evidence that continues to emerge that DOACs appear to be safe and effective. For patients that are at high risk for GI bleeding, again, consider the strategies of a lower potency agent. Apixaban appears to be the choice of agents in the setting of high risk of GI bleeding. And again, this strategy of moving from combination therapy to monotherapy to shortening the duration of therapy to reducing the potency of the agent that you choose. GI protection is always an option, and the use of proton pump inhibitors and H2 antagonists have reduced the risk of GI bleeding and are effective. And then finally, in the setting of an acute GI bleeding event, it makes sense to withhold therapy depending on the severity of the bleeding event, but always with the intent of reinitiating antithrombotic therapy at some future period. So that's our summary of this article. I hope you'll grab it. If you need a copy, please email me and I will send a copy to you. Safe anticoagulant therapy, safe antiplatelet therapies is what we're after. So good day and good luck.